Pregnancy begins with a fertilized ovum. Normally, the fertilized egg attached to the lining of the uterus. Ectopic pregnancy occurs when the fertilized egg grows outside of the uterus. The word ectopic itself means out of place. The normal place here being the uterus or bare, the uterine cavity, or its lining, the endometrium. And it's common and life-threatening. It is the leading cause of women's death in early pregnancy. And study shows that it can affect up to 1 in 80 pregnancies. How does ectopic pregnancy happens? Each month during the menstrual cycle, ovulation occurs when one of the ovaries produces an egg that is drawn into the end of the fallopian tube by the finger-like structures called the fimbriae. The fertilized egg then stays in the fallopian tube waiting to be fertilized by the male sperm. If fertilization happens, the entity formed is called a zygote. The zygote then makes its way along from the fertilization site along the fallopian tube toward the uterus where implantation will take place. The fertilized egg then implants itself into the lining of the uterus called endometrium and ultimately grows into a baby. However, sometimes this migration from the fallopian tubes to the uterus does not happen as expected. In this case, either the fertilized egg or zygote gets stuck into the fallopian tube, either it moves toward the uterine cavity and gets caught at the junction between the uterine cavity and the fallopian tube. But in other cases, the fertilized egg reaches the uterine cavity and implants on a non-uterine scar. For example, previous myomectomy scar or a prior cesarean section scar. In other cases, it reaches the uterine cavity, but instead of implanting on its lining, it crosses it and implants deeper into the uterine muscle. This is called intramural ectopic pregnancy. But again, the fertilized egg can progress all the way and fall into the cervix and implant in it. This will form an ectopic pregnancy called a cervical ectopic pregnancy. Ultimately, the fertilized egg can migrate backward and implant either on an ovary or the abdominal cavity. But sometimes the fertilization just takes place on an ovary. But if the egg is not fertilized, then both the egg and the uterine lining are discharged in the menstrual flow or period. A fresh lining is prepared and a new egg begins to mature within the ovary. So according to the anatomical site where the implantation takes place, ectopic pregnancy types include ectopic tube pregnancy, where the implantation takes place into the fallopian tube. It constitutes more than 90% of all ectopic pregnancies. Remember, the fallopian tube is anatomically divided in different segments. 3% of ectopic pregnancy are interstitial pregnancy, meaning inside the patch of the fallopian tube that crosses into the uterus. Less than 1% of ectopic pregnancy are cesarean section scar ectopic pregnancy, and less than 1% are ovarian, it means in the ovary, and another less than 1% are intramural, it means deeper in the muscle of the uterus. And another less than 1% are abdominal, it means into the abdomen. Another less than 1% are heterotopic pregnancies. We recommend you to watch the previous video on multiple pregnancy for more information. Risk factors for ectopic pregnancy include the following: prior fallopian tube surgery, previous ectopic pregnancy, endometriosis, pelvic inflammatory disease, and certain sexually transmitted infections such as gonorrhea, chlamydia can cause inflammation in the tubes and other nearby organs and increase the risk for an ectopic pregnancy. Some birth control method: For example, the chance of getting pregnant while using an intrauterine device is rare. However, if you conceive with an intrauterine device in place, it's more likely to be an ectopic pregnancy. Tubal ligation, commonly known as having your tubes tied, also raises your risk if you conceive after this procedure. Other factors that may increase a woman's risk for ectopic pregnancy include cigarette smoking. Cigarette smoking just before you get pregnant can increase the risk of an ectopic pregnancy. The more you smoke, the greater the risk. Age older than 35 years. History of infertility. Use of assisted reproductive technology such as in vitro fertilization. By about 50% of women who have an ectopic pregnancy do not have a non-risk factor. So all women in reproductive age should be aware of changes in their bodies and non-symptoms of an ectopic pregnancy. Signs and symptoms of ectopic pregnancy. The classic clinical triad of ectopic pregnancy is as follows: abdominal pain, missed periods or amenorrhea, and PV bleeding. But unfortunately, only 50% of patients present with all these three symptoms. The following symptoms have also been reported: dizziness or weakness, fever, flu-like symptoms, nausea and vomiting, syncope and cardiac arrest. The presence of the following signs suggests a surgical emergency: abdominal rigidity, involuntary gagging, and severe tenderness. Evidence of hypovolemic shock, for example, orthostatic blood pressure changes and fast heart rate or tachycardia. Findings on the pelvic examination may include the following: the uterus may be slightly enlarged and soft. Uterine or cervical motion tenderness may suggest peritoneal inflammation. Lower abdominal pain or bleeding during pregnancy may be due to a number of causes. It's however very important that an ectopic pregnancy as the cause is excluded. If not diagnosed and treated quickly, an ectopic pregnancy can lead to internal bleeding, which is a medical emergency. Some patients experience symptoms that are similar to other conditions such as gastroenteritis, urinary tract infection, pelvic inflammatory disease, and miscarriages, which are the most common ways to misdiagnose an ectopic pregnancy. In front of missed periods, accompanied by signs and symptoms like abdominal pain, shoulder tip pain, bladder problems, bowel problems, or a collapse in women in reproductive age, a suspicion of ectopic pregnancy is to be considered. Diagnosis. Diagnosis is usually suspected clinically if the patient presents one or many of the previous symptoms and signs. Confirmation is usually done by ultrasonography. But in low resource settings, when an ultrasound is not immediately available, a cardiocentesis, which consists of inserting a needle into the pouch of Douglas, can be performed to confirm the presence of a collection of blood in the lower abdomen, which in the presence of positive pregnancy tests in an early pregnancy is a strong evidence of a possible ruptured ectopic pregnancy. An exploratory laparotomy can be performed both for the diagnosis and the treatment. Serum beta HHT levels. In a normal pregnancy, the beta HHT level doubles every 48 to 72 hours until it reaches 10,000 to 20,000. In ectopic pregnancies, beta HHT levels usually increase less. The mean serum beta HHT levels are lower in ectopic pregnancies than in healthy pregnancies. But remember, no single beta HHT level is diagnostic of an ectopic pregnancy. Your beta HHT levels are necessary to differentiate between normal and abnormal pregnancies and to monitor resolution of ectopic pregnancy once therapy has been initiated. The discriminatory zone, which is the level above which an imaging should visualize a gestational sac within the uterus in a normal intrauterine pregnancy, is as follows: 1,500 to 1,800 with transvaginal ultrasound, 2,300 in multiple pregnancy, 6,000 to 6,500 for transabdominal ultrasound. The absence of intrauterine pregnancy on the scan when the beta HHT is above the discriminatory zone represents an ectopic pregnancy or a recent miscarriage. Ultrasonography scan is probably the most important tool today for diagnosing an extrauterine pregnancy. However, visualizing an intrauterine sac with or without fetal cardiac activity does not exclude an ectopic pregnancy. And here, a heterotopic pregnancy. Transvaginal ultrasonography or endovaginal ultrasonography can be used to visualize an intrauterine pregnancy 24 days post-ovulation or 38 days after the last menstrual period. But a gestational sac is usually seen by the usual transabdominal ultrasound from day 45 following the last menstrual period. So, an empty uterus on endovaginal ultrasound in patients with a serum beta HHT level greater than the discriminatory cutoff value is an ectopic pregnancy until proved otherwise. Color Doppler ultrasonography improves the diagnostic sensitivity and specificity of transvaginal ultrasonography in cases in which the gestational sac is questionable or absent. Laparoscopy. A laparoscopy remains the criterion standard for the diagnosis. However, its routine use on all patients suspected of ectopic pregnancy may lead to unnecessary risk, morbidity, and costs. Moreover, studies show that laparoscopy can miss up to 4% of early ectopic pregnancies. Key implications. Number 1. Ruptured ectopic pregnancy. When the ectopic pregnancy continues to grow, it can rupture. This is usually followed by a heavy bleeding inside the abdomen, which can lead to shock and death within hours following the rupture. But this can be avoided by an urgent intervention. 3. Anemia. Anemia can be found in patients with a ruptured ectopic pregnancy. It can also be observed even after a successful operation. Infections. Like all surgeries, surgical management of ectopic pregnancy can be complicated by infections within days following the operation. Management. The therapeutic options in ectopic pregnancy are as follows: expectant management, medical treatments, and surgery. Number 1. Expectant management. Candidate for successful expectant management should be asymptomatic and have no evidence of ruptured ectopic pregnancy nor hemodynamic instability. And moreover, they should demonstrate objective evidence of resolution, for example, declining in beta HHT levels. Two, medical treatments. Methotrexate is a standard medical treatment for unruptured ectopic pregnancy, but the ideal candidate should have the following criteria: having normal blood pressure and pulse rate. Number 2, no severe nor persisting abdominal pain. Number 3, gestational sac less than 4 cm. Number 4, the ability to follow up multiple times. Number 5, normal baseline liver and renal function test. For the methotrexate use, 2 types of regimens are common: the multiple dose regimen and the single dose regimen. Number 1, the multiple dose methotrexate regimen. It consists of administration of daily IM methotrexate of 1 mg per kg on alternate days. If there is 15% decline in beta HHT level over 2 days. The treatment is usually associated with administration of leucovorin or folinic acid to reduce methotrexate side effect. B. The single-dose IM methotrexate regimen. It consists of administering 1 dose of methotrexate 50 mg per meter square. A repeat of beta HHT level at day 4 and another dose of methotrexate 50 mg per body meter square if the beta HHT has declined less than 15% between day 4 and day 7. Methotrexate side effects include stomatitis, abdominal pain, dizziness, and rarely severe neutropenia, pneumonitis, and reversible alopecia. Absolute contraindication for methotrexate therapy include existence of an intrauterine pregnancy, weak immune system, allergy to methotrexate, active pulmonary disease, peptic ulcer disease, kidney dysfunction, breastfeeding, and evidence of ruptured ectopic pregnancy. Surgical treatment for ectopic pregnancy include: number 1, laparoscopy, which consists of inserting a tiny camera in the abdomen and find out the location of the ectopic pregnancy for laparoscopic surgical treatment. Laparoscopy has become the most recommended approach for most ectopic pregnancy cases. 2. Laparotomy. Laparotomy is usually reserved for patients with low blood pressure or in shock, which can be a sign of massive internal bleeding, or for patients with corneal ectopic pregnancies. Laparotomy is also the most preferred method in low resources setting, while laparoscopy is not readily available. For the tubal pregnancy, the surgery consists of stopping the bleeding if present, while removing the ectopic pregnancy through a salpingectomy or a linear salpingostomy. With a linear salpingostomy, the bleeding may be minimized by injecting in the mesosalpinx that's below the ectopic pregnancy a dilute solution containing 20 units of vasopressin in 20 ml of isotonic sodium chloride solution. For the ectopic abdominal pregnancy, though rare, less than 1% as mentioned previously, ectopic abdominal pregnancy are associated with high maternal mortality, very high fetal perinatal morbidity, and mortality rates. Because of this, it's generally recommended to proceed to an urgent laparotomy when the diagnosis of an ectopic abdominal pregnancy is made. But this must be discussed with the patient, whose informed consent must be obtained. But if she refuses, guidelines insinuate that the continuation of pregnancy with the careful watching or conservative treatment could be considered to bring the baby to viability, but only if the following criteria are met. Number 1, there is no major congenital malformation. Number 2, the fetus is alive. Number 3, there is continuous hospitalization in a maternity unit with possibility of immediate blood transfusion. Number 4, there is daily and careful monitoring of maternal and fetal well-being. Number 5, the placental implantation is in the lower abdomen away from the liver and the spleen. Number 6, the follow-up is assured by a multidisciplinary medical team. The choice here is largely dictated by the clinical situation. It is more to mention that the situation of an abdominal pregnancy in terms of decision-taking, diagnosis, follow-up is more complicated than it seems. Moreover, women with an ectopic abdominal pregnancy will not go into labor. Delivery in case of an advanced abdominal pregnancy will have to be via laparotomy. The survival of the baby is reduced and high perinatal mortality rates between 40% and 95% have been reported. Babies of abdominal pregnancies are prone to congenital malformation due to compression, the abscess of the uterine wall, and the often reduced amounts of amniotic fluid surrounding the fetus. The rate of malformation is estimated to be about 21%. Typical deformations are facial and cranial asymmetries and joint abnormalities. But the most common malformation are central nervous system malformation and limb defect. And once the baby has been delivered, placental management becomes another issue. In normal deliveries, the contraction of the uterus provides a powerful mechanism to control blood loss. However, in the abdominal pregnancy,
the placenta is located over tissues that cannot contract,
and attempts of its removal may lead to a life-threatening hemorrhage. Generally speaking, unless the placenta can be easily tied off and removed, it may be preferable to leave it in place and allow for natural regression. This process can take several months and can be monitored by clinical examination, checking beta HHT levels, and by ultrasound scanning, in particular Doppler ultrasonography, as the large amount of necrotic tissue is a potential site for infection. Placental vessels has been blocked by angiography embolization. Blood transfusion is frequent in patients with ectopic abdominal pregnancy. Use of tranexamic acid and recombined factor 7A also minimize blood loss. Prevention. There is no accurate way to prevent an ectopic pregnancy, but there are some ways to decrease the risk. Among them, using safe and natural family planning, limiting sexually transmitted infection, stop smoking, and if you do, quit smoking before you try to get pregnant again. It is more to mention that ruptured ectopic pregnancy is an extreme emergency for which an intervention must be performed as soon as diagnosed. So seek emergency medical help if you present severe abdominal pain with or without a PV bleeding, extreme weakness, and shoulder pain. Your doctor will perform an urgent pregnancy test, transvaginal and abdominal ultrasound, find out if you are presenting an unruptured or a ruptured ectopic pregnancy. An urgent and life-saving surgery will be performed if a ruptured ectopic pregnancy is diagnosed. I am Dr. Eric. This channel provides information that promotes health and holistic wellness, as well as lifestyle safety tips.
Wow!
All the information provided on the channel is intended for awareness, educational, and informational purpose. If not done yet, remember to subscribe now and hit notification bell. We thank you all and we hope this episode on ectopic pregnancy was helpful. See you in our next video soon.